Imagine you are a first-time mother or father at home with your infant seated in their high chair eating grapes. You turn your back, just for a second, to grab a cup of water when you suddenly hear your baby coughing forcefully. You rush over to them, and they're no longer breathing. You don't know CPR, and now you wonder why the thought of taking a class never crossed your mind. You're overcome with fear and having a hard time catching your breath. You call 911 and helplessly hold your baby as you wait for first responders to arrive. This terrifying but very real scenario sheds light on our topic today. At least one child dies from choking on food every 5 days in the US, and more than 12,000 children are taken to an emergency room each year for choking related injuries. Thus, for our project, we chose to explore infant and pediatric bystander CPR with additional choking intervention techniques. Here are my fellow student physician assistant team members. We're currently studying at the University of Southern California. From literature, we learned that statistically, bystander CPR, if done correctly, can increase survival rates for victims in cardiac arrest. We strongly believe that pediatric bystander CPR and choking intervention skills should be accessible to all parents, guardians, and adults. They deserve to be equipped with the knowledge and skills to potentially save a child or their own child's life. Knowing some of the general barriers that prevent or discourage people from learning CPR, we wanted to mitigate some of these barriers by bringing the learning to them. By introducing the topic in a comfortable and familiar environment that is not financially burdening, we hope that our intervention would produce a positive outcome for the parents and staff at the Henderson Baptist Family Daycare. For our project, we chose Service Planning Area 8, South Bay. For one, our daycare was located in this area, but we generally wanted to assist a community of underrepresented groups, as these communities were more likely to face barriers in obtaining CPR certification. Spot 8 has about 1.5 million people, with 24% being under the age of 17. Just like many others, the SWAT E community faces many disparities, such as the highest rates of unfair treatment because of race and ethnicity, the highest rate of families that receive assistance from programs such as WIC, and youth that have delayed necessary medical care due to the healthcare system and provider issues and barriers. Keeping in mind these social determinants of health, we set off on our journey to find out why people are generally not CPR certified and what barriers the community faces in regards to taking CPR classes. Could it be finances? Maybe transportation? Is it fear, uncertainty, intimidation? Let's find out.
When considering the literature to support the need for bystander CPR training in our SPA, we looked at two studies that explored the racial barriers affecting minority bystanders, as well as CPR training methods for daycare employees. The first study, entitled Racial and Ethnic Differences in Bystander CPR for Witnessed Cardiac Arrest, found that an unfortunate reality is that Black and Hispanic people in the US are less likely to survive out-of-hospital cardiac arrest than white Americans, and this could be due to less CPR skills within minority communities. Factors that contribute to this are the lack of CPR training locations and opportunities in minority neighborhoods, where historically these communities have been disinvested in and generally distrust institutions like the police. Furthermore, the study points out that access to dispatcher-assisted CPR with instructions on how bystanders can perform CPR is lacking in these communities. We suspect that another factor could be the high likelihood that these communities experience more environmental pollutants than white neighborhoods, including poorer air and water quality, are more likely to be in food deserts, and are the target for advertising of substances like tobacco and alcohol. Implicit bias, which is an unconscious and often negative view held against a group of people, could be a contributor to why community members, emergency personnel, and police are all less likely to intervene and perform CPR on Black and Hispanic people experiencing an out-of-hospital cardiac arrest. The study outlined ways these realities could be addressed and included tactics to engage trusted community leaders like pastors or church leaders and those who run community centers. Along with community support and advocacy, it would be imperative to offer low-cost or no-cost CPR training in multiple languages to equip members of minority communities with attainable, digestible, and culturally applicable CPR skills. Majority of out-of-hospital cardiac arrests occur in the home, and so empowering community members to be able to help their family members in need could be effective in addressing the racial gap in CPR proficiency. Another study, entitled Implementation and Evaluation of Resuscitation Training for Childcare Workers, examined the American Heart Association's CPR training application at daycares in Germany. The findings of this study emphasize that employees learned best in small group sizes with one skilled instructor for every 6 daycare workers. Excessive group sizes make it more difficult for participants to get hands-on feedback and leads to fear of performing skills incorrectly. This is why it's important that instructors model these skills in simulations of the most common emergencies, including choking, drowning, and traumatic brain injuries, to better reinforce CPR skills. Participants also responded well to a structured summary and debriefing in a safe and open environment to further solidify knowledge and skills. Lastly, there's not a clear consensus of how frequently childcare workers should be recertified in CPR. While the study determined via surveys that skills deteriorated after 6 months, specifically the depth of compressions and chest recoil, the general guideline currently requires recertification every 2 to 3 years.
After learning about the data through our research, we decided to focus our project on a daycare center as we felt that would be the best way to connect with parents and guardians of infants and small children. I'm going to walk you through our intervention and the ways we were inclusive, show culture humility, among other practices. So we wanted to have culture humility when deciding on the day and time of our intervention. We understood that a lot of the parents of the daycare are working individuals, therefore extra consideration was made to be respectful of their time. We wanted to choose a time where the parents were already at the daycare, so we chose afternoon during pickup, but also we're aware that parents may not be motivated to stick around after a long day of work. So we created a minute-by-minute schedule for our intervention and limited to an hour or less. Which, spoiler, it turned out to be a great intervention. The parents were so engaged, the time flew by so fast. On the day of the intervention, we started off with the pre-survey and ended with the post-survey. When providing them, we wanted to take into consideration the best way to deliver this medical material in a way that was not only inclusive, but also incorporated cultural humility and health literacy. We did that by limiting the use of medical terminology, keeping questions straightforward, and using as many layman terms as possible. One example of this was for one of our questions, we had the term Heimlich maneuver, and in parentheses added abdominal thrust, just in case someone knew the action, but not the specific term Heimlich maneuver. With delivery of the surveys, we were able to incorporate equity and inclusion. We made QR codes for the surveys in order to more effectively collect the data, but also wanted to be mindful of individuals who were not as tech savvy, so we offered physical printed copies as well. After the pre-survey we incentivized the participants with pizza and drinks for them to enjoy while watching the live demonstration performed by the PA students. We showed them CPR and choking interventions on both an infant and child's mannequin. After completing the live demonstration, we wanted to allow questions. Being aware of the cultural differences among the parents and how different communication styles they may all have, we considered that some may feel embarrassed or pressured to have to speak in front of a whole group. So rather than opening up to a group Q&A, we set up stations around the room with infant, pediatric, and adult mannequins. We let the parents decide which station they wanted to practice on and had a PA student at each mannequin able to answer questions and also guide them with their skills that we had just taught. With the hands-on portion, we made sure to be trauma-informed in our delivery, so not putting our hands on the parents' hands when teaching or correcting techniques. Instead, we fostered a see one, do one type of model, where we showed them, step back, let them try, and if any adjustments were needed, we would guide them verbally or show them ourselves on the mannequin. After the skills portion wrapped up, we had the participants complete the post-survey where their names were entered into a raffle with items we felt would be beneficial for parents of young children. Some of the items included were Frida Baby vapor drops, nose Frida, forehead thermometers, training toothbrush, and a light bag. Most of the participants left with a prize, but just in case someone wanted a different prize that they didn't win, we provided a resource sheet with all of the items as well as where they could purchase them and their cost. Being strong advocates for the parents, guardians, and staff of the daycare, we also provided informational handouts on choking prevention, as well as a handout that had free and low-cost CPR certification classes in their local area. Overall, those are some of the ways that we were able to incorporate health literacy, advocacy, and inclusion into our intervention.
Now, let's review the data that we collected from both the pre-survey and the post-survey, as well as analyze their findings. The purpose of the pre-survey was to gather more information, such as if the participants already knew how to perform CPR prior to attending the intervention. For example, we found that half of them actually did know how to, and of those that did know how to, 86% said that they learned from their job, while 14% said that they learned by taking a CPR certification class themselves. For those who were not CPR certified, we had asked them potential reasons as to why that may be. A majority had expressed that they just never considered it before. Others expressed existing time constraints as a barrier. Additionally, some simply preferred that EMTs intervene in situations like this. Only 7% of those who were not CPR certified expressed that cost was a barrier. Of note, transportation did not appear to be a reason as to why participants were not CPR certified. Additionally, in the pre-survey, there was a test of knowledge components. We assessed to see if the participants knew what to do in the event that either a baby or a child were in a situation where they were choking. For definition's sake, a baby is defined as an individual being less than 1 year of age, and a child is defined as being 1 to 10 years old. So for a choking baby, 64% reported that they were more likely to try back slaps first. Meanwhile, for a child, 74% reported that they would perform the Heimlich maneuver, which is also known as abdominal thrusts. So based on this information alone, we can see that the participants already have a good baseline knowledge as to what the appropriate next step should be. Following the live demonstration and allowing the participants to practice with mannequins, the post-survey was then administered. One question on the post-survey was about a situation where a child was described to be eating crackers and then they began to cough aggressively. 57% had recognized that a conscious child in this situation is relatively stable and that the first step to be done is actually to encourage the child to cough rather than, for example, call 911 or perform CPR. Now, when asked a similar question, except the child in the situation was eating uncut grapes, and then they developed an absent or silent cough, 64% recognized that they should be performing back blows and chest thrusts to help dislodge the food that's obstructing the airway. Another portion of the post-survey was meant to assess if the participants knew which specific techniques should be used and why. 64% correctly identified that one-handed back blows and chest thrusts should be performed in an infant that's choking and conscious. Similarly, 86% correctly identified that J-shaped abdominal thrusts, which are, again, Heimlich maneuvers, abdominal thrusts, should be performed in a child that is choking and conscious. The last test of knowledge question was slightly more complex in the sense that we gave participants a situation in which they had to decide which step they should perform first. In this situation, they had to picture themselves visiting a friend who had a 15-month-old baby that suddenly became unresponsive. All but one of the attendees selected the correct option, which was to have their friend call 911 while they began performing life-saving compressions. The last but certainly not least component of our measure and surveys was to assess the growth of knowledge. We repeated the questions from the pre-survey onto the post-survey to assess what the participants learned from our 1-hour intervention. Here on our pre-survey, you'll see that a majority believed that toys, for example, were the most common cause of choking in children. During the intervention, participants were taught that food was actually the most common cause of choking in children. So when it came to the post-survey and they were asked this question again, we saw that there was a 43% increase in attendees selecting the correct answer in this situation. Now, a tricky question that we asked on the pre-survey pertained to the signs of choking. We had asked the participants to select all that applied in terms of which signs signified choking. Many of them didn't realize that an absence of cough was a sign of choking. So when it came to the post-survey, the participants were able to identify that being unable to breathe, to speak, or to cough were all actually signs of choking. While it's important to assess the knowledge growth following an intervention, we found it necessary to also determine if there was a change in level of confidence and comfortability. In the pre-survey, there appeared to be an equal split between those who were not at all confident and those who were somewhat confident in performing CPR on a baby or child in general. By the time they were given the post-survey, there was a decrease in feeling not at all confident performing CPR. We also gathered data in terms of the overall impact of our intervention. On a scale of 1 to 4, 1 being very unlikely and 4 being very likely, we asked the participants how likely they were to sign up for a CPR class after attending our session and receiving resources. Greater than 50% expressed that they were very likely to sign up for a CPR class after attending the intervention, which is fantastic. Lastly, we wanted to gain clarity in terms of what they believed in terms of their likelihood in signing up for a CPR class, and we had asked them to provide a short answer. A majority of the responses were positive in the sense that they recognized the importance of CPR and how it can save lives. So overall, my group and I are very, very pleased with the outcome of our intervention. With that said, it's extremely important to reflect on our project as a whole, and that includes assessing the obstacles and barriers.
I'll be going over the obstacles or barriers encountered and the actual or proposed solution. An obstacle we faced was that we may have limited pediatric CPR mannequins, and there was a time constraint to get the project done. Another obstacle is that parents may feel uncomfortable sharing what their knowledge or barriers to CPR may be. Lastly, an obstacle faced was that parents may have barriers to learning CPR, such as uncomfortability or time constraints. And our solution was to reach out to Pathways, who lent us 4 pediatric mannequins. We split parents into small instructional groups and addressed the time constraint by scheduling the activities and providing dinner and at-home devices as additional incentives for parents. The solution was to emphasize that the pre/post surveys would be anonymous and inform parents that this data is solely for our group project. Our solution was to bring CPR lessons and hands-on pediatric CPR mannequin practice while guardians are picking up their kids from daycare, so it's part of their routine and somewhere familiar. We also gave take-home information regarding free CPR courses that certify at-home devices and choking hazards. To encourage expansion, we can ask parents to practice CPR at home and share resources learned with family and friends. Additionally, we can share resources with community partners such as libraries, community clinics, schools, hospitals, and other daycares. For sustainability, we can encourage the use of alternative mannequins, such as using 3 pillows, and we can give our community partners a printout of how to perform CPR. We can also inform community partners about LA County Heart Heroes, which provides free hands-on CPR training, and that can be requested through their organizations. In conclusion, our star was the engagement of participants with the material and having their follow-up questions. Another star was hands-on application with mannequins to simulate an emergency, and our wish is to expand to more community partners and develop an annual CPR event with raffles. For call to action in our own future practice, we can provide pamphlets with information on how to perform CPR and choking prevention tips. It can be a take-home flyer handed to parents, guardians, or patients that we know that work with children during annual physical visits. As providers in the future, we can promote these important skills in practice by educating our patients on how significant them stepping in could be for their child's survival rate. Additionally, we can maintain our certification. To close things out, we would like to share a nice quote from one of the parents who participated in the intervention. And they stated, "After taking the class today, I've learned that CPR is very important to know. Anything can happen at any moment, and having that skill will help save someone's life or maybe even my own." Thank you all for listening, and we would like to open the floor to any questions or comments. And lastly, attached is our citation slides. Thank you.